Welcome. This is our presentation on mental health. We're going to go over some of the things, what the problem is for mental health, what makes them a vulnerable population, some of the history, and our proposed changes to make it less of a problem.
The policy that we would like to address for our presentation is about the lack of mental health resources. The problem is that there is a limited amount of mental health care resources for the current need in the United States. 1 in 5 adults in the U.S. experience a mental illness every year. Of those with a mental illness, only about 43.3% of adults and 50.6% of youth receive mental health treatment. There are many barriers to accessing mental health services, such as limited treatment options or lack of access to available services, lack of mental health awareness or knowledge of treatment options, social stigma surrounding mental illness, such as viewing the individuals as dangerous or something that needs to be fixed and isolating them, a lack of or limited health insurance coverage with poor mental health parity. This means that insurance will not cover different mental health services and you have to pay out of pocket for it. Lack of mental health screening in primary care facilities or emergency rooms. This is where most mentally ill patients go and would be a perfect place to be diagnosed, but most of the physicians that are in these areas are either not trained for diagnosing mental illnesses, or they just don't have very much experience, and so the patient ends up not being taken care of mental health wise, and a lack of available treatment facilities and treatment providers.
So the history of mental illness is quite extensive, but for the purposes of this and how it connects to today, we'll start in the 1980s. And so in the 1980s, there was a lot of change going on in the field of mental illness. And so up until that time, mental illness was separated from health in general. And so at this time, they were making a transition to kind of combine them and moving away from the mental health asylum model to treating patients within the communities. There was also a lot of studies done at this time that looked at how prevalent mental illness was. And so in the 1980s, they came to realize that it was really prevalent. So about 1/4 of all Americans at this time could be diagnosed with mental illness, and about half of those were being treated. Now, most of those people were being treated by general physicians, which really struggled with this because they didn't have the training, and there was just a lot on the plate of the primary care providers to take care of health as well as mental health. And a lot of people just didn't have coverage for it. And so that model kind of went through, and then in the 1990s, they separated it out. And so you had mental health as a liaison to general health. And then you also had a spread of coverage for people. And so in 1996, there was a Mental Health Parity Act. And then in 2008, there was a second Parity Act to improve healthcare. And the only problem with this is that it didn't mandate that mental health was included in insurance care. And then that wasn't included until the Affordable Care Act of 2010. And this was big because it prohibited exclusions to coverage for pre-existing conditions, and it mandated that mental health was an essential aspect to insurance coverage. The only problem with that is that it still made it difficult for people to access healthcare. And so although it was mandated, we still struggle with it today. Not all people are covered under insurance. Although there is more, we're still not quite there. And mental health still is not as accessible as it needs to be for the amount of people that suffer with mental health illnesses.
There are many stakeholders involved in mental health. The primary ones are the patient, the caregiver, and the provider. The patient, that is the person who's dealing with the psychosocial disabilities. They understand the details such as help, lost work days, the stress that they're feeling, the stress that they can tell they're putting on others. So they're the most important stakeholder. Also, the caregiver includes family, friends. They are required for emotional support. They carry a big burden, and they can also carry some financial burden as well. The provider is the family practice or the mental health, the nurse practitioner. They're focused on creating a positive, healthy interaction and hopefully have positive outcomes. They want to find agreeable solutions and treatments to help the individual succeed.
When approaching this challenge, 3 real possible solutions seem to rise to the top. The first of these involves the expansion of professional roles and authority. This includes a focus on comprehensive health management by primary care clinics. Primary care physicians would be responsible for addressing both physical and mental needs. This makes complete sense as they are so interrelated. I mean, think about it. Someone who exhibits signs of depression may very likely be anemic or have low thyroid or vitamin D levels. A new mother who has just had a baby may stand in need of psychiatric support for a short period of time. An integration of both focuses provides improved care. Now, walk-in clinics would be available to address after-hour crisis intervention, thus decreasing the amount of individuals seeking care from the emergency room. The psychiatric nurse practitioners could work side by side to address special needs. In addition, by expanding prescription authority for psychiatric nurse practitioners and psychologists, and increasing the utilization of social workers, more patients will receive the individual care that they desperately need. The second solution involves recruitment. Medical students often steer clear of behavioral health simply because of the lack of financial incentives. By offering loan repayment or forgiveness programs and fellowship stipends, more medical students will give this specialty serious consideration. This is especially true with the amount of debt that is accrued right out of medical school. Salaries are also a factor. Ranked among the lowest salaries for all physicians, psychiatrists report low compensation for their services from insurance companies. This needs to change. And last of all, a growing area that can have a big impact on mental health services is telepsychiatry. While the level of reimbursement must be addressed, the ability to serve this population from a distance offers great incentives. For example, as primary care physicians take a lead role in caring for those with mental illness, telepsychiatry provides a safety net for ensuring the more complex cases are treated appropriately. The service also gives greater flexibility to the providers as it allows them to have greater reach as well as reducing their cost overhead. So, what is our choice? Let's think about it. Statistics show evidence that mental illness is increasing. Now, because of the lack of adequate mental health resources, this population is and will continue to be underserved unless something changes. Since mental health is so integral to our overall well-being, it is our belief that we must have a comprehensive solution. We must tackle this problem from all angles.
The solutions that we recommend for this problem and for this population is to improve access to professional medical help by expanding their roles of those who already practice, increase the number of practitioners, and expand telehealth for practitioners to treat from remote locations. By doing this, we make access to mental health professionals, we increase it, make it more accessible, where we would be treating more patients.
Currently, mental health is usually treated separate from physical health. Integrated health that brings mental and physical health together in the same place could help with early identification of mental health problems. Those with mental illness, they're more likely to have chronic health conditions like high blood pressure, diabetes, asthma, so they are more often already in the primary care setting. Currently, the screening for depression or other mental health issues is very low. General practitioners are usually not adequately trained in mental health identification and treatment, even though they represent a high majority of those who are treating mental health issues. The problem is they have high caseloads. There's billing concerns. There's documentation issues. There's a lack of financial compensation for time, which makes them not able to afford to take the time to address these mental health issues. There are policy changes that need to happen in order to bring this change about. One is for the government to offer incentives for providers to specialize in behavioral health, because currently we are facing a severe shortage in the healthcare system. This would enable more mental health providers to be located in a primary care setting and deliver care in a primary care clinic. We also need adequate billing codes that cover things such as general behavioral health, preventative treatment, and management of behavioral health. Electronic health records need to be better suited for mental health billing and to coordinate with the primary care setting. Advanced psychiatric pharmacology for psychiatric nurse practitioners and psychologists could be very helpful, as well as more training for primary care physicians and pediatricians.
The intended outcomes of our suggested policies include the less wait time for evaluation and treatment, decreased aggravation of symptoms, such as less suicide, decreased cost by limiting emergency department visits, improved continuity of care, improved treatment choices, more support to underserved communities, increased recruitment of healthcare providers, and improved job satisfaction for behavioral health professionals.
Thank you for spending some time with us and talking about mental health and going over some of the things that we have to share with you. These are our references. We hope that you enjoyed it. Thank you so much.